Right, we're going to structure this by each panel member having 2 minutes initially to set out their initial thoughts on looking ahead for sexual health, and then we are going to open it up for the panel debate. So I will be bringing your contributions to a close after 2 minutes so that we've got as much time as possible for interactions with the audience. Did you realise this?
No.
No? Right, so how much potato do you actually have then? Right, can you do, Olwen, are we going to start with you then? 2 minutes. Thank you, starting from now.
Hello, my name's Olwen Williams. I've been a consultant in Wales now for 25 years, and I'm currently the president of BASH. So where's my vision for the future? I think we have come a long way in the last 25 years in Wales, and we've got a long way to go. Lots of the things we've been discussing this morning are things that we've been talking about for the last 15 years. So what are our drivers for change? Top one has got to be technology and our tech-savvy community. Now, it's not just the young people that are getting STIs, it's actually across the whole age range. The baby boomers are just as likely of picking up their chlamydia, their HIV, and their multi-resistant gonorrhea as our 16-year-olds. Actually, at the moment, they're probably more likely because evidence shows us that our 16-year-olds are less sexually active than our ager silver surfers like myself. So that is one challenge we've got. So we've got to make our services accessible across the piece, for the young, for the middle-aged, and for the old. The second thing is that our second challenge and the future is how are we going to actually challenge some of the risks that we've got of emerging infections. We're seeing multi-resistant gonorrhea coming, and more gonorrhea and syphilis than we've ever seen in Wales before. How are we going to actually address them? So we're only going to be addressing them by actually very good prevention, testing, and having appropriate antimicrobial stewardship across the piece. So that actually means not only our sexual health clinics being aware of what the resistance patterns that we're seeing, but also our primary care comrades, and also being aware that azithromycin is becoming a very dirty word in the field of sexual health. Our fourth area is around diversity, inclusivity, our LGBT community, and making sure that we reduce that stigma that we're currently seeing. And actually maybe some of the stigma we're seeing is not from us delivering it in sexual health, but our other people who see patients or individuals who are requesting sexual health services, and how those individuals approach individuals. In other words, the secondary stigma. So other healthcare workers' stigma around STIs and sexual health services being put on patients and making them not want to attend. You know, why would you want to go there? That has been said recently. So that's number 3 challenge. Number 4 challenge, hey, it would be lovely if we didn't have any unplanned pregnancies, wouldn't it? It'd be lovely if we had sort of some nice little implants that lasted for 10 years that you could put out. I think I'm going to shut up now.
Thank you. Giri.
Right. Thank you. I'm Giri Shankar. I'm the lead professional consultant for health protection working for Public Health Wales. I think the prompt before the start of this panel discussion with the responses to Mentimeter is itself very telling, that the constant common theme that is emerging in those responses is prevention, education. So those seem to be the bedrock of what we want to do in the future. Base all our interventions around prevention, early diagnosis, identifying the diverse needs of the various communities, which has very evidently come out in the review findings this morning, which I presented. And I think in Wales, in particular, we've got fantastic opportunity, not only the challenges, but all the opportunities. We've got legislation in the form of Wellbeing of Future Generations Act, which looks at how we can plan for the future generations, not only the medium term, but much longer term, as well as how we can integrate in a smallish country compared to other countries, how the interaction between various people who are involved in the gamut of provision of sexual health services, whether it's educational departments, health, social care, and within health, which is our primary focus of discussions here, is embedding the integration of services, whether in primary care, making more use of these things. But the other challenge that I also foresee is that we will be moving into, whether we like it or not, a period of austerity, where we will be financial resources will be more difficult to come by. So this now, more than ever before, will be the time when we will have to think more innovatively, more collaboratively about how we can deliver these services. But as much as there are challenges, I'm optimistic that there are opportunities too.
Yes, hello. First of all, I'd like to say something that isn't within my exact remit. I'm a member of the Faculty of Sexual and Reproductive Healthcare, and I'm a consultant here in Cardiff. My main remit is community service delivery. But Amanda, who is the Welsh chair for the faculty, who can't be here today, I'm sure would like to have said at this point that we need to address inequality in abortion care. That is, as I said, not my remit, but there's still a huge proportion of Welsh women who have to access abortion care in England, whether that's because they apply privately or the NHS in Wales does pay for it. Nonetheless, they have major travel issues with regards to that. And one of the reasons that we're not providing the abortion care we should in Wales is that we have old-fashioned legal frameworks that do not serve the purpose, so something needs to be done in that area. Going forward, what I would like to say with regards to just contraceptive provision, I think we need to really think very clearly about resources and what we do with our time. I feel that within the tertiary and secondary service, we need to see the people we really need to see. And within contraception, from where I'm sitting, that means we need to focus on two areas where contraception can be provided in other settings. One of those is for people who are at high risk and who will cost us as a taxpayer, as the NHS, as the individual UHB, a huge amount of money. These are women who sit in substance or access substance misuse services, women who are already have children in care, women who are homeless. These are the sort of people where a huge or resourceful input from our side will have a huge benefit to the wider nation. And I think the other is trying to move people who just need routine contraception that is reasonably uncomplicated into reasonably uncomplicated settings. There are a lot of women out there like us who are perfectly well informed, they know what they want, and they just need to go and access it. So I would see that in the form of provision of over-the-counter contraception, oral contraception in particular, pharmacy provision of further contraception that could involve things like injections, provision of contraception in the immediate postpartum areas through midwives. So these are all things where with very little input, actually we can reach women with effective contraception. That's, from where I'm sitting, that's the way forward.
Thank you, and Marion.
Oh, last but not least, I can't disagree with anything my colleagues have said, but I'm going to go back to basics here and think, we have to be on the prevent agenda all the time. So I do support the SRE revisit. I think empowering people to care for their sexual health as they would their dental health and everything else is crucial, and it should be the norm for young people going forward, that they know how to protect themselves, they know their rights, they know, how to avoid bullying and sexting and all the rest of these issues. But on the other hand, we are where we are today, and we know from the review that we have, quite large inequalities, both in services, and certainly abortion services is one of those, but in rural communities, prison health, homelessness, substance misuse services. So we need now to think over the next year or two, how do we bring the same standard of service provision to those communities as we would to the wider communities? And going forward, it is going to be the reality that the integrated services will not be able to meet the demand. But they work in a community of providers. And I would like health boards to look at their own needs over the next year and consider for their population, which of the people that Rachel identified today that do not need to turn up in Cardiff and Vale, but could have their needs met in community pharmacy services, in primary care, condom card schemes, and other providers. And I think that is the challenge over the next 2 to 3 years will be to make that a reality. We know there are opportunities now with the contracts for community pharmacy, etc. So we have to just recognise where we're at. Utopia is a long way down the line, but actually a good needs assessment, an understanding of your providers on your patch and who can deliver what, I think is the crucial next step for many of you.
Thank you. Thank you. They all said that without taking a breath. Thank you, members of the panel. Now I'm going to open it up for questions. I'm sure that there will be much food for thought in the panel members' opening remarks. So who wants to start off questioning? Marie, the gentleman there. Thank you.
Hi, my name's John. I'm from Swansea Council's. I'm the young person's sexual health and digital engagement worker, and I also deal with the C-card scheme there. It's been really great to sort of hear people talk about prevention, education, contraception in different settings, links to substance misuse and homelessness. And I know there's been some mention of some of the pressures on C-card schemes. I guess I really just wanted to say that there are some fantastic C-card schemes out there, but they're in trouble at the moment. We're really, really struggling with C-card schemes. I've spoken to other people here today, and we've had a great C-card scheme in Swansea for 16, 17 years, and we're seeing young people not even know that we exist anymore. And in Swansea, in our example, we've seen ourselves over a period of over a decade reduce teenage conceptions. And we've now, last year, for the first time in a very long time, seen the little spike and turn up the other way. So I guess what I want to say, it's great to hear all of this, but I do worry that in 2 or 3 years' time, we're going to have lost over a decade's worth of work if we really don't get some action soon. So I just wanted to, sorry to sound negative.
Thank you. Which panel member like to pick up on that? There was obviously resonance in the room to that.
Thank you very much, John. I'm sort of presuming when you say you're in trouble, you mean financial trouble, is that correct?
Yeah, funding as well.
Yeah, funding, yeah.
We've gone from a team of 5 staff to a team of 5 posts.
Yeah.
And I've seen over 4 years a 95% drop in young people accessing C-card schemes, and my time being taken up with supporting young people to access terminations and dealing with pregnancy tests.
Yeah.
And sometimes I see more of those than I would in condoms.
I think it does reflect what Giri was sort of alluding to, the fact that actually for all of us, whatever setting we're in, I think we're not going to look at a time of increased funding. And in fact, a lot of us are going to look at quite a lot of less funding. I myself, I'm a bit fed up with this sort of idea of working smarter. We've done a lot of working smarter, I think we all have in this room, And yet it's our reality. I think it's really important that we all concentrate on what is the best and most sort of effective back pay for what we're putting out there and what we're putting in. And I think you're absolutely right. We do need to look at services that can provide stuff, and that would include C-card service. I think it's fantastic what's delivered through these services, and it's a shame to see some of that go. I do want to be a bit tentative on sort of just looking at teenage conceptions, which through the ONS data always lag behind a couple of years. And also we don't entirely know what's what. I'd also love to think that whatever we've done is actually being the cause of reduced teenage pregnancy. We don't actually know that. And likewise, do we not know that in the way up? I think we've just got to keep with the evidence base and look at the fundings that we've got and really think very clearly, where are we best invested in doing this? I totally agree that, a place that should prevent should not be spending their time referring young women into termination services, and maybe that in itself could be done differently. It's got to be about what do I need to do with the money that I have to deliver what is best for the population I'm trying to serve. It's got to be at the frontline question. And, I'm sitting up here, I'm equally frustrated. We see less and less funding every year as well, but we all need to think along those lines, because if we keep moaning, we will not deliver a service at all in the end. And I'm not trying to say that you were moaning here. Yeah? I just think it's really important to keep that in mind.
Thank you.
Josie Smith, Public Health Wales. Just carrying on the theme of the economics and the resources available, I know, Giri, this morning you mentioned that the cost effectiveness study hadn't yet been completed. Is it intended that part of the work will continue? Because one of the strongest things that may support future change is the economic assessment and an evaluation of our current situation and what costs might be incurred in any changes moving forward.
Thanks, Josie. I think, yes, in the time scale of the review, I think that particular component, we were unable to address that in the level of depth we would have liked to. And the reason for that being that in order to assess a particular provision of service, we needed to have a baseline spec, a service spec against which you would actually cost the service and then look at outcomes as a measure of effectiveness. That at the moment, there is no agreed service spec around some of these things. There is a piece of work which has already been done through the part of the Sexual Health Network. A draft service spec was developed in 2012. For various reasons, it has not been put into operation, but a revision of that service spec is currently being undertaken. Zoe is leading that piece of work. We've drafted the service spec. It has gone out for consultation with colleagues. Very valuable inputs have already come back. So after further refinement, that service spec will be kind of a national template, if you like. I'm very mindful that health boards will have to adapt and there will be variations suitable to the need for them. But we will have a baseline service spec and hopefully that will pave the way for more economic assessment of the service provision.
Any other panel members want to comment on? No? Not there. Do we have any further questions?
Sandra Williams, school nurse from Powys again. It's my understanding that if you break your leg in Wales and you have to go to England to have it mended, then Wales are charged for that service. But if you go to England for your sexual health services, there's no charge to Wales. Am I correct in that?
Yes, I've just been working with the Department of Health around cross-charging, and actually that has always been the case and it will continue to be the case. There is some cross-charging around HIV care though, but for GU, sexual health, contraception, no, you don't get cross-charged at all. So if someone is in university though, and they've registered with a GP, so they're a Welsh born and bred, and they go to Manchester, then it's actually Manchester that picks up the bill there.
So do we feel then that that has an effect on the incentive of health boards to provide sexual health services? When we looked at the map before and there was no sexual health clinics in Powys, do we feel that, you know, the fact that it's not costing Powys anything because people are going to other places to get that sexual health service could have an impact on their incentive to provide those services?
Can I say a little bit, because part of my service is in Wrexham or has been in Wrexham, it's a two-way pathway. The amount of people coming over from England to get services in Wales is equal, mainly because of what's happened in the Shropshire, Telford and border areas as regards their own delivery, because actually they've gone to online testing, so if you want a chlamydia test then you have to actually have a postcode and, you know, and no services. So I don't think it's an incentive to not have services. It's where would you base your services, and you probably need a very different model for Powys.
Yes, yeah.
And actually it's about that modelling. What you need is someone as, a nurse-delivered model with oversight from doctors, from maybe adjoining health boards, which, is doable. But and the complex cases moving north or east or south or what.
Thank you, thank you.
Hello, it's me again. I'm not quite sure how to frame this, Chris. I've been thinking about it. This time last year we had a conference and it was on adverse childhood experiences. And I was interested, I've been sitting here today thinking, there's a certain amount of crossover here. And I've not heard it mentioned at all throughout the day. And I just wondered, because it seems to me that people who are using sexual health services, or the children we talked about today, who may have parents who have been service users in different ways, often embedded in those communities where there are significant social and economic issues that create problems for them that manifest themselves in what we're terming these days ACEs. And I just wondered whether or not people in the room perhaps are aware of the ACEs work that's going on and see their role within that structure. It's about, I think this is about the integration stuff and the collaboration, the understanding, the synergy between different agendas and different professions and different groups.
Yeah, I would agree. I would imagine that some of the younger clients that Rachel would like to see would be the teenagers who've had some of these adverse childhood events, because it's likely that they are going to be the more vulnerable. And there's no doubt about it, as we get a more sophisticated model for delivery, so Rachel won't be seeing all the ones she doesn't need to see. I think that is the time, actually, to start engaging with communities where these vulnerable individuals are coming from, and see where, specialist services like sexual health services can actually support and educate and inform, whether that's other professionals like police, like social care. There is a role here, you're absolutely right. And I think it's worth putting on the agenda for consideration.
And we did a sort of an audit in the Sexual Assault Referral Centre in North Wales around adverse event and childhood events. We found that 75% of our survivors, both adult and childhood, had some form, had mental health problems, and they had a significant amount of, childhood events that probably led to that. So we were going to do some work with Public Health Wales, but there was a lot of issues around actually getting around the data there. But I do agree that there is some links. I think what we haven't touched on today is that undercurrent of child sexual exploitation, and we're very aware in North Wales that we've got probably about 700 cases at the moment under investigation. We do know that about 57% of them were coming through sexual health and weren't being picked up directly because of the subtlety of things. Now we're much more aware of that. So again, I think sexual health services do have a huge place to play, but bringing that sort of CSE thing into CCAD, into all, making sure that we've got the safeguarding right, because it is so subtle.
Also, just to add, I think colleagues may be aware that recently Public Health Wales, in partnership with the police agency, has launched a big project around adverse childhood experiences, and I'm sure this sexual health issue and sexual health exploitation issue is very much part of the agenda, not only as much as you said, Olwen, about health professionals being aware of the training, it's also partners in community, including our colleagues in the police department, being aware of these issues. You want to say something?
I just want to add to that, it's important not to forget that it's not just the event to the child itself, but the event to the mother as well that have a huge impact. So a simple thing as an unplanned pregnancy and the rise of domestic violence around even a pregnancy that may then end in a termination, these are all adverse childhood events. There's a much wider picture, and I think actually there's a huge overlap between the two that has not been tapped into in Wales at the moment.
We'll take one final question, please.
This is just to take the ACEs link a little bit further. I've been quite surprised in some of the ACEs prevention work that teenage pregnancy prevention hasn't been seen as one of the essential ways of preventing adverse childhood experiences, because young pregnancy is such a strong factor in ACEs. So I would like to see that more explicitly worked into our prevention work. I'd also think that if we're looking at preventing of early pregnancy, we could also take it further and look at preconceptual advice as being a useful thing for prevention of all sorts of, improving health in pregnancy, as well as ACEs prevention. And I think there's possibly a place for sexual health services, contraception services, for including a question about, were you thinking of trying for a baby in the next few years? And then there's a set of preconceptual advice, which would be really helpful for all sorts of things.
That's a new research project for someone today, isn't it? You have to have outputs from all these meetings.
Thank you very much. At that point, I'm going to bring our event today to an end. thank our panel members and all our speakers from earlier this afternoon and this morning. And for me, it's been a real privilege to be here today and to chair the event. And it's been quite clear, to me anyway, that the sexual health landscape is changing so dramatically. I mean, you're immersed in it every day, but for someone like me, it's very evident now that the traditional focus on things like STIs and unplanned pregnancy, while they're still really important, as we've heard, the agenda is evolving and widening so significantly to include areas around stigma, gender identity, online safety, body images, a whole range of safeguarding matters. Very, very strong theme on prevention, and we've heard that again this afternoon, both around interventions to support very risky behaviours, but also about a much bigger focus on communicating and engaging with clients and needing to recognise how different client groups will access the information that they need. We've heard about the 50% increase in attendances in sexual health clinics, which is increasing pressure on an already pressurised and squeezed service. And as Marion said, we need to think much more smartly and creatively about how to provide services. And there's this big theme around equity, around the need to reduce inequalities, the need to take away discrimination in terms of access. And parts of Wales are still very difficult for a number of clients to access services, as we've heard. We've talked also about the need to mine the data that we have, to use the research that we have, and we've heard today about the very rich research work we have underway, and as Olwen has said, the potential for further research. So I'd like to thank Marie Griffiths, Jamie Wyatt and Sarah James, together with Malcolm Ward, for the organisation of the event, and particularly to thank you for being with us for the day, for expressing your opinions through Mentimeter, and for really engaging so constructively in what is such an important agenda for the current and future generations of Wales. Diolch yn fawr iawn. Thank you.